Welcome back, everyone, to another episode of Sisto Says, powered by Design 2147, a New York City building and code consulting firm. Today, I have an absolute honor to have Tony Caputo
Hey, my man.
from HDR Inc. He is the principal of health. Tony, been a long time to get you on the show, but
That's
I got
right.
you here.
Yeah, I appreciate you having me on. It's
welcome aboard.
fantastic to get together.
So just to enlighten the team a little bit about Tony, I met Tony about a year and a half ago in the networking, the power of people. Always believe in the power of people to meet new people. Who now is a true friend of mine, Chris McDonald. He was working at HDR Inc. at the time, and he had introduced me to you, and we got together. We chatted a little bit about the healthcare world. And, you know, I always start the show, Tony, nobody wakes up one day and says, you know, when they're in middle school somewhere and goes, hey, you know, I'm going to be a principal of health for HDR Inc. There's a path. And the health, you know, designing hospitals, designing clinics, designing anything related to health is complex. So tell us how you got there.
It was definitely a long road. I think, you know, if I go all the way back in terms of origin story, I always like to make things, right? I had my father's shop. I would make things around my house. I would tear down the fence and build something with the wood, like that type of thing. But it wasn't until I got to architecture school and out of architecture school, I had the opportunity. One of my first healthcare projects that I worked on was I moved. I was working for Canon Design at the time.
Yeah, we still do work for Canon.
I moved from the Grand Island office out to LA to be the senior designer on a healthcare project there. And I had the fortunate ability in my early career to work on really fast track projects. So within the first 7 years of my career, I already had 3 major 200,000 square foot size projects, an airport, and 2 hospitals that were built because they
at
were
least you
designed.
started off with the non-complex stuff.
Yeah, exactly. So one of the first major ones was I was living in LA. We won a project for Arizona State Hospital for a new 280-bed inpatient behavioral rehabilitation facility for the state of Arizona. So I was living in LA. And I had an apartment in Phoenix because I was the Phoenix office too for about a year and a half with McCarthy Construction out of Southwest. And you really learn a lot going through projects in that depth. And when I moved back to New York, I was still with that same firm at the time. I worked on another major hospital project out at Jacobi Medical Center. We were doing a major addition there.
Yep.
I did in 2003. I started the major modernization expansion of Stony Brook University Hospital, which was another project of mine, start to finish, beautiful building. And then it sort of evolved from there. My careers, I've experience in many different project types. I've done lab buildings, you know, giant commercial office buildings in Egypt and all sorts around the world, airports. But it really has been like a focus in healthcare. I think I'm connected to it in the sense that some of the most difficult problems that we have to figure out are, you know, healthcare projects because they have so many different user groups and constituencies that all have to work together in the most complex nature. And this, the aspect of healthcare being about multiple things, not only that patient experience, but that staff experience. And those have to be like dualities that you plan for simultaneously is really intriguing to me.
And the thing that, you know, when we first, and this is a quick story, but a true story, way back when in 1988, I had started design while I was at City College as a junior, and I was working for a plumbing company, and that plumbing company worked with all major GCs. They were a union shop, and we did a lot of hospital work and a lot of airports, Taggart Associates. And I was there as a draftsman, and then from draftsman, I became the head purchasing agent. The gentleman retired, and while I was going to college, I was buying but I got to talk to everybody. Got to talk to people at Morse Diesel, got to talk to people at Bovis. So I made a lot of connections. And at one point, a colleague of mine who worked at Morse Diesel, his name was Bob Holmes, he called me up and he said, hey, sister, listen, there's a rumor out that, you know, you're doing expediting. I know you left Taggart. You know, we have a project. Would you like to come and meet me? I said, sure. So I go go meet him at Morse Diesel's office, and my partner Dominic comes with me, Tony, and we get in there, and they got this huge roll of plants. I mean, it was like this big, and they got them out on this big table.
50-gallon drum of plants.
Oh my God, it was massive. And he goes, well, we were just awarded NYU Skirball Hall. We're going to decommission 2 streets, and we're going to build a hospital to branch it from both to both, and it's going to be the new main entrance. And he says, do you know how to get a street closed? Do you know how to get this street unmapped? Because we have to pull all the utility. And I'm like, yeah, we know how to do everything. Well, we get in the elevator on the way out, and my partner, Dom, who's like my older brother, he's 2 years older than me, but we know each other since we're 5. He picks me up in the elevator and goes, are you crazy? You don't know how to do any of this. And that was our first major job.
You got to jump in.
And then from there, we worked on so many hospitals in New York City. And now we're slowly, over 4 decades, things evolve, right? And hospitals used to be great because there was one person who ran that hospital. But over time, these large hospital groups went and bought these smaller private, and it became much more corporate, and it was harder to maintain that long relationship. So like right now, we still do a lot of work up in the Bronx for a few of the hospitals there because they're still the same people. It didn't really change. So people play a big role, but the hospital world, we talked a little bit about this off the set, is the patient, the doctors, the staff, and the caretakers that are going to see their patients, and what's their experience like in a hospital. Yeah. So tell us a little bit about where you started and where we've evolved a little bit to where we are today, because we always talk about it. Everybody wants you to fill out a survey. What was your experience like? What's it going to be? What is it? How you doing? So tell us a little bit about where you see architecture going there.
It's interesting. So from like a design perspective, I think when I started working on this, we always had this concept of, the patient experience and the staff experience. And we would refer to this as the on-stage experience or the off-stage experience. And the one thing that we didn't mention is there's that like invisible hand of like services, right? Services have to be fully invisible too. But the complexity with the healthcare systems, I see what we see now is these large replacements. We're getting hospital systems that are the usable lifespan of the buildings that they were in have far exceeded, some have exceeded 75 years old, you're approaching, and you're floor to floors and aging infrastructure and all the things that go along with it. So one side, what we're seeing across the country now are large scale replacements that requires a lot of capital investment up front.
Sure.
What we still see in New York are the infrastructure projects where everyone's working around. On. So you have to be nimble and how you are
to repurpose what they have. It's
not just about how we're designing them for that patient experience and the family experience, the visitor experience to come and meet the patient. We've been working on ways of providing those places of respite. I mean, hospitals are one. They're the places, moments of joy that occur in them, but there are also places of tragedy that happen, and you have to be conscious of that and give the families spaces to have moments to decompress, moments to be consulted, moments to just be alone.
It's not just a patient room. It's not just an OR. It's not just an ER. There's so much more going on, and I just experienced that. I became a grandfather, and my daughter-in-law had twin boys, but they were prenatal. They were 29 weeks. So we spent a lot of time at the hospital. And the hospital was, first of all, the people were amazing. The hospital was incredible. But it's old. Yeah. It has everything you need, but you can tell the lifespan, and for them to shut it down, to upgrade it, to do it, it's not just, hey, we'll just do this. There's so much that has to happen to relocate that I can understand how, hey, it's a 10-year plan, and then it gets to the 10th year, it becomes the 11th year, then it becomes the 15th year. Right. And before you know it, we're 25 years.
You get to these moments of logistics exceeding your desire to have the capital investment
exactly
for it, and what's the impact or what's the value that you're going to get after you go through this 7 years. You have to justify it with these capital spends. But the public spaces are being more amenity driven.
Oh, definitely.
We're seeing concierge services. We're seeing increases across the board to in-room dining. I mean, we're doing a project out in California right now. The restaurant is a Michelin star rated restaurant. So they that is like the focus on the family and the visitor space.
Yeah.
From the staff perspective, it's, really embedded in the intelligence of the design. Some of the key things you want to reduce, staff injury. So you look at the design of rooms, how patients are being moved throughout the facility,
which is a big deal.
Where services are provided. So you're reducing the steps and the fatigue on the nursing staff, and then also providing them an experience,
Sure.
in
Their
themselves.
locker rooms.
How they arrive in the facility. And when we were up in Hartford, the moment of arrival from the staff started at the parking garage. So you think about it. It's like, where does their experience start? The patients and the visitors get to walk in this front door in a beautiful multi-story atrium. The staff arrives in a parking garage. So, like, what's that experience?
Right.
So at Hartford, we made sure that they had their gym facility built into their dedicated parking garage, and then they had food services and amenities and a connecting bridge that wove them through the campus.
That's a big part of their retaining their nurses and their doctors, right? Retaining the people that work there, and it's not just them. There's the people in facilities. There's the cleaners. There's everybody. So the whole thing changes. I think last year you and I had a conversation over lunch, and we were talking about you walk down the street now, and there's so many urgent cares around, right? And I'm old school. I still go to a little GP. I never got into the whole thing, and I pay for it because he's only concierge now, right? So but when you call him, you go there and you get there, and he's got a little room, and you wait, and he's cordial, and the people that work there are
that's
great.
your doctor for life.
That's your doctor for life. But yet you'll walk down the street now and you'll see these urgent care places that the architecture is so inviting that it's not about their experience in there, because they're probably going to go in there and see a PA and not even see a doctor.
Well,
but from a sales standpoint,
the outpatient model is, especially in the urgent care model, where it's not an emergency department where you have to admit a patient into the inpatient setting. It's retail focused.
It's retail focused.
So we see this like retail focus that, you have your city MDs and all those types of things, but everybody has their own urgent care model. There are other health networks that provide their own insurance. So they usually have like a community center, like adapted into their program. So it sort of ties in.
And they're all designed differently. I know where I live in Stanford, we've opened up a lot of urgent care instead of, and this was a model 30 years ago of trying to keep people out of the emergency room, because if they have a cold or a cough, they shouldn't be going to the ER. Yeah. They should be going somewhere else, right? But they call their local doctor. The doctor doesn't have an appointment. They panic and they run to the ER. Yeah. But you've also noticed that these bigger hospitals are branding themselves with these urgent cares as well, and their designs have changed. Yeah. They're not tucked in the back of a building anymore. They're more retail oriented themselves. They've changed their concept.
Rapid imaging, you get in, you get out, where you don't have like an admitting path, because really the change, it's all being driven in the back end by what you don't see, which is changes in like the reimbursement models, and that has been debated ad nauseum, and it continues to change for the past 2 decades, and even before. It goes back to the days when doctors were encouraged in the 90s, right, to be their own landlords and have their practice. And then that model fell through, and then practices started getting absorbing. And I think we're going to see moving forward is the incentive reimbursement model, especially in Medicaid, Medicare, the level of reimbursement changing, whether it's the services are provided on campus or off campus. Gotcha. So all the systems are going to have to start to rethink what is in their outpatient, their community outreach
and what's
locations, and what's actually located on campus.
Well, that makes a lot of sense. I mean, and when you look
at the cost of healthcare is the thing that's really driving.
Oh, I mean, just and the experience, right, Tony? So to give you a quick one that my wife is a 2-time breast cancer survivor, right? And she has to go for a PET scan every year. And our hospital just built, Stanford Hospital, Skanska actually built it. It is a beautiful, beautiful place. My son works at the hospital. He's in the facilities division doing construction. And my wife goes for her MRI, and they have it at a off-site, which was probably 15 years ago. Beautiful building, the Tully Center. But they don't have a PET scan machine. So they bring
a mobile.
They bring a mobile.
Yeah.
So my wife goes, and she goes down, and they bring her in at the desk, and then she goes down the elevator. She goes out the back
She's
through
got to
this
go into a
basement.
double wide trailer.
Right, and she goes in the trailer. And then on the way back, she comes back, and she gets home, and she says to me, "You know, sister, I was really, really disappointed."
Yeah.
I said, "For what?" She goes, "They took me through this dingy basement. Garbage was out. They took me down with someone I didn't even know. I told the gentleman I needed to go to the bathroom. He sends me down this hallway into this bathroom. I says, well, you know what, Tony, and you need to do something about it." And she wrote a letter to the hospital to say that, look, the care is great, but the experience was horrendous.
Right.
Whether it's me or anybody else, what happens if this is like my mother, who's 84 years old, who has to go get a PET scan? She's going to go down these steps and through this.
Yeah.
She said it was so you can, even though we have a lot of space, the economics drive that because, right, Tony? I mean, if they had the money, they'd put the PET scan on.
Well, it was probably, and the technology was unforeseen at the time that they had built it. And as technology evolves, their physical facilities can't keep up with that.
You can't keep opening buildings.
That's the race in healthcare, right?
Yes.
It's a good technology
So
continues
how
to
does
evolve.
someone like you try to inform your client that by the time you dig the hole and you finish a 300,000 square foot hospital, that by the time you get to the end, technology already could have passed up what you already designed?
Well, I mean, we are the standards for spaces are continuously evolving, so we try to future-proof in that way. The infrastructure, needed for those things, we try to see foresight in that. But it's all about, really smart strategic planning in the beginning. How if you're going to invest in renovating, let's just say sometimes that's the more complex problem.
The adaptive reuse.
We build a new hospital from scratch. We can see all the program. We can make smart decisions up front before anything's built.
Sure.
But if you're trying to fit programs into existing spaces,
Like in New York
and
City.
keep all the operational flows that are there, you have to be really clear about that. We also see it's not also about, as the modalities change, we're seeing this in emergency departments, older style of racetrack emergency departments where we're planning new dual track emergency departments, which give the opportunity for patients to be diverted in their experience to where they're needed in a more triage focused kind of approach. Sometimes if you've been running a hospital for 40 years, the 30 years, 50 years, and the staff, 20 years for the staff there, they're used to working in a certain way. So it's also about how you educate the staff in that sort of transitional planning model to get them to understand how it is they're using they're going to be using their new facility. I was having this conversation with the client the other day, brand new emergency department. They said, Tony, we keep falling back into our own ways. And I use this car analogy. I say, you've got the Corvette, but you don't know how to get it past third gear. Let us help you get it, past third gear on the track here. So,
yeah, and a lot of times we talk about architecture, but we don't talk about the psychological part of architecture.
Right.
We're used to going to an airport a certain way. We're used to going to people are used to working in a space the same way. It becomes this routine. And the minute you change, directional signals, the way you wheel the stretcher in, the way you wheel the stretcher out. If they've been doing it a certain way for 20 years, first of all, they don't like change. Most humans don't like change.
Well, these are complex problems, right?
Right.
You have the wayfinding aspect.
Right.
You have the operational aspect.
And
you have the
wayfinding,
planning
excuse me,
aspect.
but in hospitals, wayfinding is huge.
Right.
Huge, because you go in and when you get there, you go to the information desk, and a lot of times the person's saying, "Okay, go past the second elevator, make a left, make a right, do this,
it's all
do that."
landmarks.
It's all right, exactly. It's
If
all
you see the
landmarks.
yellow sign, you've gone too far, yeah.
And then I remember being at Brooklyn Hospital. They used to have like follow the green dots, and you used to walk on the
Some
dots.
people use the yellow brick road, methodology.
But how many back in the day? We used to go from building to building in Manhattan. We weren't in a building. They bought 10 buildings on a square block.
So what's interesting is when we do these things, and you ask how we plan early to provide for those experiences, right? I always try to, my career is like focused on the architecture and the public spaces, and I've always had really good partners who are my healthcare planners, right? I know enough to kind of be dangerous in the room early on, but it really takes a team of experts to do what we do. And I would always work early to pull parts of the program, because you say, all right, we have a 100,000 square foot new building and a 2,000 square foot lobby. I would work to pull pieces of that program which were important to transition the public to the patient side.
And that's the part you liked.
Into the public space. So then it becomes about this organization of these portals, departmental portals, and the logic of that within the public realm. So you use the lobbies, the atriums, the public spaces to be a point of sort of decompression,
right?
To take a moment of respite, to pause, and for like clarity and intent. And then your experience starts from there.
Right. And you could tell that on the renovated lobbies, it's a much different experience. There's a lot more space to lounge. There's just it almost feels as though you feel like you're in some hospitality place versus a hospital. Yeah. Where I remember as a kid, you used to go to the hospital, visit your grandmother, or somebody was like, "Oh my God, this is sad."
Well, now you go. The difference is you go with entire families go.
Right.
So you have to cater to larger groups of people.
Correct.
Right. So you're
corralling. You see that.
You're creating multiple places for people to break out. There's group like furniture, just even the organization of furniture. There's group seating because people will go and campfire together, as opposed to like having to sit next to someone you don't know,
right,
shoulder to shoulder on a couch,
right,
for extended periods of time. People are coming in there and they're like working while they're waiting in the lounge. You have a same day surgery.
Oh, there's a lot of people that I saw on this experience. There was a lot of people that were workers because the restaurant was, the facility that they had there where they were serving hot lunch and everything. And it was a regular, like, small little diner, like. It kind of reminded me of a diner with some booths and stuff. But people would grab their lunch and they'd be in the main lobby of the hotel having their lunch. And they were the workers because they didn't want to be in that small little room that some architect gave them 25 years ago. So that part of it is true. And, it's funny, Tony, that when I started this show, I said to myself, well, how am I going to get guests to come on and talk about something? And I realized how many experts there are in our field, right? And I'll give you an example. I had one person who came on, and she was from Collective. She did, Waypoint. That's her whole industry.
Right.
And how much architects and owners rely on moving people around within a complex building. And then a couple of weeks ago, I had Lori Huntner on from WB Wood. She does furniture. And you say, well, why would you have a furniture person? They're trying to sell furniture. Well, we talked about schools. We talked about hospitals. And she says when the furniture business is good, the construction business is good. Okay. She goes, because hospitals have to worry about a lot of things. They want it to be clean. They want it to be fresh. They want it to be new. They want people to be comfortable. And you'd say, well, how would furniture... But yet, the more I do the show, the more you realize how there's all these other little things, that it's not just about the grand poobah Tony Caputo who's designing it, but it's all of these other people that make a great building. Yeah. And in the healthcare world, there's more and more and more and more layers just across the board.
So one of the most complex problems there that you can try to solve, and because it takes a team of experts in order to be able to do it. So having done this for, some few decades at this
Come
point.
on.
Yeah, all right, 30 years, fine. But having done that, you really realize that. And it's about orchestrating.
Right.
It's about orchestrating that. From
Every band needs a
early in my
leader.
career when I was like solely focused on design only, I could take a much more bullish approach on why that was the most important thing. But I was doing the public spaces and the design of the buildings on the campuses and how people got in and out of them. And that was very, very important to me. And the logics now of it, though, are about that total experience from arrival. And we talk about this. It's not just about where people come in. That doesn't, often mean that that's the place where they're going to leave. They happen to leave at different points. So
I'll tell you what,
you
when
have
I
to-
kept
you have to
going,
design the entire.
when I kept going to see the grandkids, once I kept coming in the same way,
Yeah,
and I
you knew a
finally
shortcut.
realized there was another door somewhere closer. You figure it out,
figure
right?
it out,
But
right.
but there's no way as an architect that you could make people get to that shortcut first. Their first vision is, I'm going to the hospital. I'm going to go through the main entrance.
Front
right?
door, yeah.
Then you realize, oh well, they don't have parking here, so I got to drive around, go to the lot. Oh, what do you mean? I could go to the third floor and there was a door there with a security guard? Okay, well that works great.
You really go next level when you've been doing it long enough that you have key card access to all the basement and infrastructure tunnels, and then you can get anywhere you want through tunnels. But yeah.
So Tony, good friend of mine, friend of yours as well, Andrew Peters. He came on the show at the very beginning, probably about 100 episodes before you, and we talked about estimating, and he created this piece of the show that I use every week with my guests. And he talks about looking in the future. And he said, when you do estimating and someone comes to you and says, hey, I'd like to build a 200,000 square foot hospital in New York City. How much is it going to cost per square foot? And the man doesn't have a set of drawings. He has nothing. He barely has a program. But he tries to give the owner and the architect some sort of guidance of what that cost per square foot. He's going to pick your brain. He's going to pick other people's brain. But he always said that the rear view mirror is this big and the windshield is this big. We look back a little bit, but really we got to look forward. So here we are, 2026. We got a lot of AI stuff, and we don't want to talk about AI because that'll bore everybody because everybody talks about it all the time. But as an architect, 2026, what do you think the biggest change in the design of hospitals is going to be as we look into the future? What do you see the world looking for?
It's interesting. So there's growing, just in terms of the design of the spaces, I want to zoom it out. Maybe I'll go back to.
It's a subjective question.
I go back to this. My basis of when people say, "What do you do?" and I say, "I make things." They just happen to be architecture, right? It's that foresight. It's like what we do, what we're planning to do now. Just the path. I don't see a lot of fast track anymore. The developer market's kind of tightened up a little bit. And when you're working on these hospital campuses or replacing the hospital campus, these are long-term, 7 to 10. I used to say I lived my life 5 years at a time because that's how long the projects would take. Now they're 7 years, 10 years.
And it's funny you bring that up because we're also noticing that in a lot of the large scale projects that we do in education, that they always were a 2-3 year.
Right.
Now we're looking at projects where they're telling us the due dates are 3032, 3033, because the master plan and shifting people and moving things, there's just so much to go into these projects that they're not. I think they've realized that fast tracking everything, just because you get it done fast, it doesn't mean it's done right.
So I think the looking in the mirror part is the understanding of that entire process, for me anyway, and then using that in a process of like decision making and advising our clients on how and when the decisions that they make affect things at a future date, and not 3 years from now, if we're still in design or we're in construction and something needs to change, how we can allow ourselves the flexibility in the decisions we're making now, so that the impact of a future decision isn't so great that it basically negates itself from even starting.
That's a great answer.
Yeah.
That's a great answer, because I think that there's no question that AI is going to play a big role in everything that we do. I mean, we see it on a small scale, but around the world, everybody's racing to it, and it's going to be part of what we're going to, what the world is going to be like. I mean, it's no stopping it. But in terms of architecture, I think the other thing is, I think that the architects today are much more aware of the customer experience for the patient, for the family, for the staff, for the doc, for everybody. I don't think it's as, and maybe I was just naive, but I definitely see the change that it seems to be that it's not just focused on the patients or the staff or the doctors, but like you said, more people are going to the hospital. They're going in bigger groups. They're spending more time there. They allow longer hours. They like us, we could have spent, we could sleep there if we had to, as grandparents. So definitely, I see that part of it is become more social.
Yeah, and one of the things I think, just playing off of that, tying into this idea of advancements in technology and integration into space, I was on this quest for a while where I would always say the whole interior of the space, the whole atrium can be white. It can all be white, because it's about the space. It's about your experience in that space. And as I start to drive technology, some of the things that we're looking at now are embedding ways I'm working a lot with behavioral health environments and design for patients who have like spectral issues and on the spectrum. And I'm working in technologies of how we design our spaces, material choices, focusing in on acoustics and lighting to help create like decompressive environments.
Sure.
So that when you enter into the space, there's a natural calming.
You're not
overstimulated. It's about like just tamping that down enough to give that patient that moment of respite that they need, because it may be a new experience for the visitor, or but the person that the stress is causing the most to is the patient itself.
Sure.
So like, how do we focus on that as patient first sort of experience, and learn to, integrate technologies to help calm that environment that the patient
100%. Because like you said, the first day we went there, it was incredibly stressful. 2 little babies getting born, 10 weeks early, incredibly stressful, and then 8 weeks later, incredibly joyful. So as an architect, that's a wide, sad, incredibly happy, right? But as always, Tony, great conversation. So great that you made the time. I always appreciate.
I appreciate it too. Yeah.
Thank you.
Thanks, sis.